Hey everyone, welcome to At the Bedside. I'm John Martindale. I'll be leading today's episode. The goal is to keep it under 5 minutes, so we're going to move pretty quickly. Alright, so there's a 63-year-old man who presents with left leg pain and numbness for 2 hours. About 2 hours prior to arrival, he had sudden onset left arm pain and left-sided chest pain. However, that resolved after 15 minutes. Since then, he's had persistent numbness, weakness, and severe pain from the mid-thigh of his left leg down. He currently lives in a shelter. He's a 35-pack-year smoker. He has a history of heavy alcohol use, though he says he hasn't had a drink in 2 years. He does occasionally smoke marijuana, and he denies illicit drug use. You can see from his vitals here below, he is tachycardic, slightly hypertensive, and tachypnic. So before watching this week's episode, I want you to think about your differential diagnosis for this patient, given what we have so far. What specific answers do you want from your targeted physical exam? What imaging or labs do you want to supplement that physical exam? And then what are the key elements to consider as to whether or not this gentleman stays in the hospital with us tonight or whether he can go home? On my physical exam, I had a gentleman in acute distress. He had no murmurs, rubs, gallops. He was clear to auscultation bilaterally. He had strength as 1 out of 5 on his left lower extremity as compared to his right, which was full strength. He had no sensation below the mid-thigh on that left side. He had a pulseless DP and PT on my palpation, so I grabbed a Doppler. Again, on the Doppler, wasn't able to get a signal on the DP, PT, or I went a little higher to the popliteal. Again, no signal. Here's my differential diagnosis. So, top of my list, stroke, acute coronary syndrome or heart attack, femoral artery occlusion, aortic dissection, a herniated disc, or a cord compressive lesion or abscess. The things that I considered were peripheral neuropathy, peripheral artery disease, DVT, compartment syndrome, is this simple sciatica, and is this spinal stenosis. So what's next in your workup? What I decided to do was to grab an ultrasound. I put the ultrasound on his popliteal artery. You can see here we have vein superficial, artery deep. What you can't tell here is that I do have a color Doppler on, and we're getting no flow despite me rocking back and forth. On the right side, I jumped up to the femoral, and you can see we have flow here, but on the arterial side, not the venous side. And there's something strange going on in the lumen of this femoral artery. Those of you who are especially astute will see that I have the probe flipped here, so the artery should be on the other side. The next step was to go up to the lower abdomen to try to figure out what was going on with the lumen there in the femoral artery. Inferior vena cava, here we have abdominal aorta, and you can see a small flap going across there in the aorta. So this is what an aortic dissection looks like on ultrasound. On the right side, I'll show you the color flow. You see turbulent flow around that intimal flap. And here's that CT scan. So the thoracic CT will do here on the left, and the abdominal CT will do on the right. I'd like for you to go back, rewind, watch this video a couple times. You can see intimal flap there, which propagates all the way down. Right here, there's ascending aorta, descending aorta. And then down in the abdomen here, you see propagating in both infrarenals there, continues on down. Right about here is where we saw it on ultrasound on those prior images. And then it goes down into both iliacs as well. Alright, so takeaways from this case. Always consider those life-threatening diagnoses first, and make sure you roll those out before marching down your differential diagnosis. Verify your GR's assessment, and don't delay off of a low acuity. Aortic dissection may occur at any point in the aorta, and therefore presentations vary. So keep a low threshold, especially in a patient with a vascular and neurologic complaint. Once you identify a dissection, you want to get aggressive with blood pressure and heart rate control. And finally, consider ultrasound an extension of your physical exam. Use it to tailor what you order next. So know this gentleman wasn't going to the operating room off the ultrasound alone, but it did significantly speed up our process in getting the correct diagnosis for him and getting him to the operating room. A little follow-up on this gentleman. A week and a half after presentation, I went and saw him in the cardiovascular step-down unit. He was doing really well. He had his stent placed, he was working with physical therapy, and was up and out of the bed, on his way to making a full recovery. Okay guys, thank you so much. I hope to do more of these in the future, so please give me your feedback, and I hope you'll have a great day.